Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
In this episode, I sat down with my partner, Dr. Sequoia Ducasse, and we discuss heel pain, how endoscopic plantar fasciotomy was integrated into the profession more than 3 decades ago, and some very interesting and different takes on heel pain, its complexity, and what the future may be with staging and grading the plantar fascia with diagnostic ultrasound. I think you'll find several important things that can help your practice throughout this conversation. It's always fun for me to sit down with my partner and just discuss things because things come up that we can't really even plan. And I know that you've experienced that when you've gone to a meeting where the question and answer session is actually better than the presentation that was given, because sometimes you have to be unscripted. And this episode, in all aspects, is totally unscripted. I hope you enjoy it. All right, good day, everyone. I'm here with my partner, Dr. Sequoia Ducasse, and we're going to talk about heel pain. This is the first of 5 episodes that we have planned on heel pain specifically. So I'm really excited that you came up here today to hang out with us and chat about something that I've been immersed in for, I guess, now about 35 years. So
yeah, for sure. Thank you for having me, allowing me to sort of drink from the cup here.
Well, I'm going to pour you a lot, so let's keep drinking.
Okay. So we want to jump into this heel pain. First of all, I think heel pain has been the bane of, the existence of many a podiatrist and podiatric surgeon, figuring out the etiology of the heel pain. Most of the patients we see in our practice have heel pain. You've certainly seen a lot of heel pain. How did you get into managing heel pain? When you first started out, how did you evolve?
Well, it's a big evolution for sure. And I guess it started out in my residency when we would see folks that had open plantar fasciotomies come down to the podiatry department. And some of these folks were 1 year post-op and still unable to bear any weight. And at that time, my thought process was never operate on heel pain because these are really terrible outcomes. And then that changed. Early in my practice, I was fortunate enough to befriend a hand surgeon who one day at the scrub sink said, I've learned this new technique at a hand meeting where they're actually putting this little TV camera inside the carpal tunnel and releasing it. And I was like, wow, that's fascinating. And he said, do you want to hang out with me on Saturday and we'll do some cadavers here at the surgery center? And I said, yeah, I'll be there. So when I showed up and saw the instrumentation, the first thing I saw once I looked at the monitor was the deep surface of the volar carpal ligament. And I thought, my God, that just looks like plantar fascia. And so I remember going home that Saturday afternoon after a cadaver lab experience and called up my practice manager and said, get us some cadavers because I think I've got a technique that I want to look into. And it took us a good 6 months with different prototypes of instrumentation. And then I can remember the first patient, and this is not a HIPAA violation because he's given me permission to do speaking and use his photo and name in the in talks and whatnot. So with Calvin, I told him that, we had exhausted all conservative means. We had done orthotics, steroid injections, stretching, everything that was pretty well known at that time. And I said, we've got this new technique where we can, use a scope and make small incisions. And if you want to try that, he's like, well, yeah, I'm all for that. So I remember we did hit his surgery in the office that afternoon. It was a Friday afternoon, and really didn't know how to manage it post-operatively. I just told him, if you can walk on it. And if it's too tender, then you stay off of it. And so on Monday, he came in, and he was at his regular work boots. I'm like, wow. I didn't really tell him to take his dressing off or anything, but he had taken his dressing off, and he went to work that day as a machinist. And that's a pretty demanding job because he's standing on the hard surface all day. And he said, I don't know. He goes, the heel pain's gone. It's a little tender where, you put the incisions, but so we learned a lot from these early patients. And then we looked into, more patients, and we got a series of patients. We published some early articles in Journal of Foot and Ankle Surgery, and then people started calling us up, like, when are you going to start training? And we published an article, I believe it was 652 patients, and it was a multi-surgery surgeon study, and we started learning a lot. We learned that you didn't need to cut the whole plantar fascia, cut the medial 1/3, you decrease your lateral column destabilization phenomena. But all of that was really clinically based data that we just made observations and then adjusted the technique from that.
Right.
And that changed really the whole situation for the way I looked at heel pain. And in a way, at that time, looking back retrospectively, it probably gave me a little bit of tunnel vision because we just thought, well, if they don't get better with the usual things, we can just cut their fascia. And at that time, everyone referred to the condition as heel spur syndrome. And we knew at that time that the spur had nothing to do with the genesis of pain because we weren't doing anything with the spur. And then you would look at other literature sources. There was a meta-analysis. It was small, but I believe it was Anderson and Foster, but we can verify that for the audience and put it in the show notes. But anyhow, they looked at it and they found in the series of patients that had the spur resected, they had about an 85% success rate. And in the series of patients that just had the fasciotomy alone, those folks had a 95% success rate. So what that said to me was, well, we can decrease your success by 10% if we take this spur out. And everybody was in love with the spur. Right.
Because, people get fixated on the spur. You see it on the x-ray, it looks very ominous, right? The foot surgeon has been fixated on the spur for a really long time. So I imagine when you introduce this new procedure, it sort of rattled a few feathers.
Oh, yeah. It not only rattled a few feathers, I still have some of the scars from the arrows in my back. I mean, I recall so one of my colleagues stood up at one of the Texas Podiatric Medical Association meeting and said, "There's these two sons of bitches sticking scopes in people's feet. Can you imagine that?" And interestingly enough, that gentleman then came to one of our training courses about 6 to 8 months later. So the results spoke for themselves.
Right.
But no, there was a hell of a lot of controversy. And if you want to go back to the spur, the spur's been the demon.
Right.
It's the devil incarnate. And people love to look at the spur on an x-ray and patients can see it. It's like, wow, that's really a big spur. And so you did have to educate them that really the spur is not causing the pain. And the literature was, I think, replete enough at that time that you could explain that to the patient. And when they got better, they were perfectly yeah, I got the spur, but I don't have the pain anymore.
Right. The spur just belongs to me, but it's not generating any pain.
Right. And then you fast forward a few years, maybe 10, 15, and then some more data comes out. But we'll get to that in a little bit. But to go back, we had to kind of re-educate a lot of our folks that came through the training courses that, you're not treating the spur. The fact of the matter is you're treating the plantar fascia, and you mess with the spur, you decrease your success rate. So we were able to get it, I think, over a period of time. The literature started referring to it more as heel pain syndrome, which is really a much more accurate nomenclature than heel spur syndrome.
Yeah.
But, still surgeons today, they love to put that x-ray up and say, look at this, Mrs. Jones, this was the spur, and look at this nice, smooth calcaneus. And I took that big monster out of there. Sorry, you still can't walk.
Yeah, but she still has pain.
Right.
But no spur.
Right, no spur.
Right.
But still a lot of pain. So, I think the way a lot of folks, and myself included, were trained is that, we were highly X-ray image driven.
Yeah. Mm-hmm.
And we know that imaging doesn't always correlate to clinical results, positive or negative.
Right. So, to circle back to the whole nomenclature deal, right? We switched a little bit from the heel spur syndrome to the heel pain syndrome, but we're still stuck with plantar fasciitis.
Yes.
Right. I think you're going to overturn a few dogmas here when we start digging real deep into this. But are you telling me that it's not an inflammatory issue when we talk about plantar fasciitis?
Well, it's not me telling you that. It's the literature. So we're going down our path merrily along, and we're doing endoscopic plantar fasciotomies, and most people are getting, really good results. And then in 2003, an article comes out, and Harvey Lamont was one of the authors. And I believe they took out 50 specimens at the time of plantar fasciectomies. And the pathologist saw no histological markers of inflammation in any of those 50 specimens. And so the question was, is this a degenerative process rather than an inflammatory process? Now, that article really was kind of a life-changing thing for me, because I thought, wow, maybe we've gotten it all wrong. And I think it's still wrong. And I think use of the word plantar fasciitis is inherently wrong, but it's been ingrained in the nomenclature for so long, it'll take a period of time to overcome. But if you look at the most recent articles that are published, usually in the introduction, they'll say, it probably should be referred to as plantar fasciopathy or plantar fasciosis because it's more of a degenerative process rather than an inflammatory process. Now, where that rocked a lot of people's boats was not necessarily why endoscopic plantar fasciotomy worked, but why did the steroid work that I'm injecting with, right?
Right. So if it's not inflammatory, why does it respond to an anti-inflammatory?
Yeah, so the answer is that we know that NSAIDs also have, the ability to mediate pain in the spinal level. It's been demonstrated very well that in the mucoid deposition in the plantar fasciopathy, that there are these nociceptive chemicals that, the steroid will help with, but not necessarily via an anti-inflammatory mechanism. And if you look in the orthopedic literature now, you rarely see the word tendinitis anymore. It's always now tendinosis, thanks to guys like Nick Mafuli, who've looked at these things as degenerative rather than itis, inflammation.
Mm-hmm.
So, and then you can look at an article, I believe it was by Atley, probably early 2000s, where they looked at, I think it was about 60 patients in each arm, where they compared lidocaine injections without anything to steroid injections. And they found that there was no difference.
Right.
So the only difference is you inject a bunch of steroids all of the time, you're going to get fat pad atrophy, and then you have another problem on top of what you had.
Yeah.
So, but then in the early 2000s, I was coerced into adopting ultrasound. So then that it's like, after a couple of days with the machine in the office, I'm thinking, why did it take me so long to get this? You really are stupid. And because now we knew what we were dealing with.
Mm-hmm.
We had these people come in. Some of them had been put in a cast for a year for their plantar fasciitis, in quotes. And
they're sleeping with night splints. They're, exhausting physical therapy. No one really knows what to do with this thing because I guess at that time we couldn't figure it out exactly what it was or how to,
Right. And we're going to talk about, staging and grading, I believe, in the next episode. But what was real interesting is a lot of these folks that were diagnosed with plantar fasciitis did not have any issues with their plantar fascia at all. But if we look at the literature, it says about 93%. That's one of the numbers. I think that's way too high, but about 93% of heel pain is due to plantar fascia.
Right. Yeah.
And I think in reality, that number is high. I think if you look at an article that Rose and Millay published where they looked at a series of patients that presented with heel pain or what they thought was plantar fasciopathy, fasciitis, I believe was the term they used at that time. I think it was like 72% of the folks had a coexistent nerve entrapment.
Right.
So we have evolved. The technology's there, the literature's there, but the profession is not there yet. A lot of people diagnose heel pain by, does it hurt first thing in the morning? They press on the bottom of their heel with their thumb, and then they give them a steroid injection, and they strap them or pad them and put them into orthotics, and it's a cookie cutter approach. And it's kind of sad because with the technology that we have today, you can actually see, am I dealing with a mouse or am I dealing with an elephant? And everything else in medicine is always staged and graded. And you want to know the severity of what you're dealing with, because early cases of plantar fasciitis or fasciopathy respond very well to certain conservative
treatment options.
Yeah. And then it's absolutely ridiculous to force a patient to endure 6 months of failed conservative care before you can technically operate on them. Yeah. I don't know where that dogma came from, but that's old. That's so old. It's, older than me.
Yeah. Well, that was going to be the next thing is that, a lot of the patients that come into private practice, I would say probably pretty close to almost half of the patients that walk in through the door have some type of heel issue, right? There's some type of heel pain. How do you determine, 20 years ago, the bright light came on and it's no longer plantar fasciitis, it's plantar fasciopathy, right? So how do you determine or how do you try to change the mindset that all heel pain, number one, is not equal, right? There's some aspects that, again, may have the neurogenic component, like in the Rose article.
Right.
And how do you know which ones are going to, do well with the conservative treatment or not?
Right. Well, it comes down to accurate diagnosis. So the more you can dial in with really determining what are the factors that are contributing to this person's heel pain, the better chance you have of implementing the right treatment, the right care. I remember one night I was flying up to Baltimore to meet with my mentor, Dr. Dellon, and put a heel pain segment in his training for the lower extremity peripheral nerve surgery. And I didn't really have exactly what I wanted. And there was a magazine left in the front of the back of the seat in front of me. And I pulled it out. It was a Cosmopolitan. Now, normally I don't read Cosmopolitan, but for some reason I was bored and, and so I'm thumbing through this and there was this questionnaire. And it was, what's your likelihood to have breast cancer? And the first thing I thought is, probably pretty small. I'm not going to have breast cancer. But men do get it occasionally. Mm-hmm. But that being aside, they had a different scoring. They had a scoring system. Like
Right.
if mother had it, your sister had it.
Yeah,
blah,
you check
blah,
the
blah.
boxes.
Yeah,
right.
exactly. And if it added up to a certain amount of points down at the bottom, then you had more of a risk or less of a risk. You still needed to follow up with a provider. But I thought, well, why can't we do that with heel pain? Because we know that there are certain things you can pick up in the HPI that patients will tell you very, like one thing that's almost always pathognomonic is that if they say the orthotic makes them worse. And they can't
tolerate anything in that arch.
Yeah. Tarsal tunnel should pop up in your mind as one of your differential diagnoses. So we developed this thing called the MEPS, Multiple Etiology Heel Pain Syndrome questionnaire. It's on our website today. So if any of you all want to steal it, have at it, But that questionnaire has not been scientifically validated, but it's proved to be pretty accurate. We know that in some early clinical testing of it with different practitioners, it's pretty good. And that could be a study that we want to look at, get our nerve fellow going on it. Because you could blind them, you could blind that, and you could, have pretty robust scientific method behind that and validate it. But to go back, when we started implementing that questionnaire, because a lot of people didn't have ultrasound technology, the purpose was at that time, let's try to get something in the clinician's hands that will give them maybe more of an idea of where to look, right? Mm-hmm. And we went to the people that had taken our courses, and I tried to get that disseminated around and everything, but it really hasn't been adopted too much. And I think it's a good tool. But then the next thing is, listen to your patient. Take that extra couple minutes during the HPI, because they're going to tell you a lot of interesting things about their condition that might clue you in from an examination standpoint. Then in the exam, make sure you're looking for these nerve entrapments and how much equinus do they have. Mm-hmm. Nobody seems to think about equinus. Yeah. They want to operate on all of these things up in the forefoot, and they've never thought about, well, how much contracture does this poor person have that's causing that overload of their forefoot? The forefoot, and you and I see these all the time. They're disasters because they've had, weird types of metatarsal osteotomies. They've had Morton's neuromas resected, and I hate that terminology too, but I'll let myself get away with it for this period of time. For today only. And I'll be fined for that, by the officials of the plot of inquiry for using the wrong terminology on that. But anyhow, then when people start looking for nerve entrapments, start implementing ultrasound, and start really putting it all together, there's a much better chance that you really know what you're dealing with. Yeah. And so it goes to the conservative care standpoint.
Yeah.
There's really nothing conservative about putting somebody through a lot of time, expense, keeping them in pain if you know that plantar fascia is just really very sick and very degenerated. They're not going to get better without some type of an intervention. And I'm not talking about a steroid injection. Yeah. So,
well, I think the treatment of plantar fascia has not improved greatly over the time span of maybe when you did your training and when I did my training. I think the algorithm is pretty much the same, right? The patient comes in, you press on that plantar fascia, plantar medial calcaneal tubercle, it hurts. They tell you first step out of bed, then it kind of eases up. You may tell them, get in a night splint. You're blindly putting a steroid shot in there, right? You may or may not have done an x-ray, but the treatment process, just like you're saying, we kind of subject them to this long process of conservative treatment options. And then if that doesn't work, now we're implementing the whole EPF deal, thanks to you, of course. But I think staging and being able to figure out, is this something that, has a neurogenic component, number one. Number two, the other big deal is utilizing ultrasound and figuring out if you're going to inject it, making sure that you're putting whatever you're putting in the right space, anatomic compartment, right?
Right.
And there was an article about that, some cadaveric studies where, what did they inject, some methylene blue, or what was it?
Well, I don't think it's been published, but we actually looked at that with 3 different practitioners and I think 6 specimens each, and asked them to just blindly inject, based on topographical anatomy and palpation, a little bit of methylene blue. And then we would dissect that specimen to see how much was in the fascia itself versus the subcutaneous fat or whatever. And I think out of the 18 specimens, there were only 6 where it was actually
only in the fascia.
Only in the fascia.
Right.
So your thumb's not as good as you think your thumb is, and your 3D perception is not as good as your perception of what your 3D perception is.
Right.
And so I think that lends the credence to, using ultrasonography during these types of guided injections. And that's going to definitely increase your efficacy and your outcomes for patients.
Yeah.
So.
Yeah.
But no, I think you're right. When you look at where is the profession in plantar fasciitis, because that's where we're
still calling it that, right?
It's no different than the 1970s. And with the technology we have, it's an absolute crime that that a big paradigm shift hasn't occurred, because we have the technology, we have the literature, and treatment could be just so much better. And, how frustrating is it for the practitioner as well as the patient to keep adjusting an orthotic over and over and over again,
when the orthotic may be contributing to the pain.
Exactly. Right. And they may not have plantar fasciopathy
to begin
at all.
with.
Right. So anyhow, but it's a very interesting saga, and it's very frustrating in a way because, these people, the patients deserve better than that. And I don't think anyone, and I'll probably get in trouble for saying this, but I'm at the stage of life where I really don't care anymore. But I don't, totally unfiltered here. But I really think that if you're holding yourself out as an expert in the treatment of heel pain and you do not implement ultrasound imaging, then there's something wrong with that. That's disingenuous. And maybe your ego's bigger than your brain, because your thumb is not as good as high resolution ultrasonography. Just not. And I've tried to tell people that, but anyhow. Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. This episode is sponsored by Savant Cellars, providers of boutique Tier 1 Reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Cellars. You may just never want to come out until it's gone. Savant Cellars sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals, and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at SavantCellars.com. That is CEVANT Cellars.com. SPELUNK15. Yeah, but it's very interesting. And how many cases do we see that are so complex? They've had, 6, 7, 8 operations.
Yeah.
They still have heel pain.
Yeah. I mean, we see a lot of these patients coming into the practice because, again, our practice is sort of the court of last resort, right?
Right.
And a patient may go to a physician, and nowadays with the availability of, Dr. Google, a lot of patients come in self-diagnosed. And I think some of the physicians are not really spending the time to dive really deep and, say to the patient, yes, it may be this, but you may likely have this other thing happening, like we spoke about with the equinus, right?
Right.
I was told that, women get plantar fasciitis because they like to wear heels, right?
Right.
And, men are not suffering as much because I guess they don't wear heels. Well, I guess some men probably
Well, it's changing.
do wear a little bit of heels.
Depends how you wake up that morning and what you identify, right? But to make a comment, to reinforce that, is when I was in practice down in Texas, a lot of the males that suffered from heel pain would tell me that when they wore their cowboy boots,
they felt better.
They felt better.
Right.
Right. So that was, in contradistinction to what you would think.
Exactly.
Right.
So, it probably goes along with the whole equinus deal too, right? So, I think plantar fasciopathy has to evolve. The treatment of it, the identification of it, the general public education of what to expect when you're being treated for plantar fasciitis. The surgeons have to be a bit more or a bit less gun shy when it comes to when is the appropriate time to recommend a surgical intervention for this patient, right? And not just stick them in 6 months of physical therapy and night splints for 2 years.
Right.
And if you can identify with, fairly good confidence that you're dealing with something that from the beginning may likely not respond to conservative treatment options, then you're fully well justified in recommending something surgical, and you shouldn't be afraid of that.
Right. And we're going to talk about that a lot in our episode on staging and grading. And, if you call the pest control guy and you say, hey, I've got something that's, really tearing up the house, the pest control guy is going to want to know, well, what kind of animal am I dealing with? Is it a mouse or you got a raccoon in there?
Right.
Because they're going to be totally different treatments. And the same thing with the plantar fascia. It's absolutely silly that you treat patient A at 9 a.m. with plantar fasciitis the same way you treat patient B at 1 p.m. with plantar fasciitis, because they could be wholly different situations of degeneration.
Mm-hmm.
And so to put them into this one-size-fits-all cookie-cutter algorithm, I guess that's what you have to do when you see 70 patients a day, because you can't really take time to think about these things. And then people get messed up. They have weird things done that pushes them down. We've got one patient now that's had calcaneal osteotomy and, young, 20-some years old. And we can't figure out really what's going on with this patient.
Mm-hmm.
And so, but yeah, I think that's between the Morton's neuroma mythology and the plantar fascia mythology. Those are the two biggest myths of the profession right now. And I don't know what needs to be done to kind of turn the dial, so to speak, to another channel. And so people tune into a little bit different, because the literature's certainly there.
Yeah, the literature is there, but I was going to say in medicine, I guess the literature is still fairly young, right?
Right.
20 years in medicine, it probably hasn't even made it into a textbook as yet.
Right. That
nomenclature change is probably still just, so if you're not actively a student and, of the profession and reading what's out there, you probably would. I'm sure there are people graduating from school now and residency, they're still treating this and believe that it's inflammation that's causing this.
Right. Oh, I see it all the time, in our, trade newsletters and whatnot, patients treating plantar fasciitis, it's an inflammatory condition, blah, blah, blah. And it's like, wow, how long does it take? But when you were doing your nerve fellowship with me, what was your experience in residency? How did they look at plantar fascia and heel pain back then?
Yeah, well, the first time that I heard you tell a patient that it was not inflammatory, I distinctly remember writing that down. this guy is crazy.
You might be still right on that.
Yeah. I go, what does he mean that the fascia is not inflamed? Because I just never heard that before, right? And so I think we probably had a conversation about that almost immediately after. I go, did I just hear you tell this patient that it's not inflammatory? And so we kind of started down that little rabbit hole a bit there. But 100%, I was still, I would shadow physicians and they would say, this is inflammatory. I got to put a little steroid in here to knock the inflammation down. And you'll be just fine. We may have to put 1 or 2 in there. Some people are injecting through the plantar aspect of the foot. Some people are doing medially. You never, and then the concoction that they're putting in is different, is night and day from each individual person. Whether I never saw anyone putting in dextrose, which we know is beneficial as well, right?
Right.
But there's usually some combination of an anesthetic and an anti-inflammatory, some steroid or something like that. And, they're putting it in there with like a 22 gauge needle because you hear that the steroid's not going to go through a 27 or a 30 gauge, right? So, you're subjecting the patient to all of this discomfort when you're sort of just blindly treating or everyone gets the same mixed bag of tricks, right?
Right.
Someone comes in with plantar fasciitis and, okay, step 1 is this, step 2 is this, and step 3 is this, and it's the same for each person.
Right.
So yeah, I mean, and I didn't graduate from residency in the early 1700s, like
me.
Right. I was fairly recently, but we're still treating it the same way.
Right.
And even when I talk to a few of, the people that I graduated with and I'm trying to explain this to them, they're just, it's sort of over their heads. Like, what do you mean? I'm still going to do the same thing because I'm getting some benefit.
Well, are they?
Right.
That's the whole thing. It's like, patient doesn't come back because maybe they're better, or patient comes back because maybe they're not better and they went someplace else to try to get better.
Right, because they thought maybe you couldn't help them.
Right.
Mm-hmm.
Yeah. No, it's very interesting, and there's a lot that we're going to talk about as far as regenerative therapy. We were one of the first to start injections of PRP, and I just find it ironic now that that's the hot new thing. Well, it was hot and new 20 years ago, but today, and now we're looking at peptides, which are fascinating, and we're going to have a whole section on that. But, people ask me, well, is endoscopic plantar fasciotomy still a viable procedure? And the answer is very definitely. And we do implement EPF in our arsenal, but because of the ability to treat things from a regenerative standpoint, we don't need to cut the fascia.
Yeah. We're using it less and less.
Yeah. But it's still a very valid and an extremely efficacious procedure for. I mean, of all of the things, in podiatric medicine and surgery, it may have, if properly done, as with everything, it may have one of the highest success rates, and it's got an extremely low complication rate, again, if it's done correctly.
Yeah, patients recover pretty seamlessly.
They do.
Right.
And so, no, it's still a very valuable surgical procedure. But if I don't have to get to that point, why would I want to cut their fascia when I can make it regenerate with, BPC 157?
Right, some peptides or whatever. Yeah.
Yeah. So sometimes less is more if it's the right less. And you know what you're dealing with. So I guess, circling back on the whole thing, my philosophy or outlook is constantly evolving because there's new literature, there's, new findings all of the time. We see different things. We're starting to look at, well, in these people that are so recalcitrant to everything, is there something going on intraosseously, right, that hasn't been looked at? Maybe there's an abnormal interosseous pressure. We don't know that. And that's something that's maybe the next horizon. Because, everybody, and I think the other problem with heel pain and plantar fasciitis is that the average practitioner just arbitrarily dismisses it as like, oh, this is nothing to it. blah, blah, blah. But for some people, it actually is not simple. And we end up with those folks, and they've had multiple procedures, and they've had, now they have post-surgical PTSD, and they're not getting better. And, and there's some, I think I've got 5 on the top of my mind that I just don't know the answer. We've had grand rounds. We've had, multiple people look at them, all the imaging studies. And so some cases, unfortunately, are extremely complex and beyond my ability to, treat it effectively. And it's very humbling and very frustrating at the same time. But it also is motivating that we have to keep looking down different sources. One of the new things that hopefully we can get the radiologist from Stanford to come on the show about this S1 PET MR combo imaging that is able to identify the receptor that is really dealing with pain versus what we think.
Yeah, that's really cool.
Yeah, no, it's going to be very cool. So,
to hear you say after you've been doing this for a really long time that treating plantar fasciitis, which is sort of the bread and butter for us, right?
Right.
Us as a profession, is frustrating and humbling, and you don't really know, what's going to be successful right off the bat. How does the practitioner who's listening to this, who is curious on, maybe changing their central theory related to plantar fascia, where do they start?
Well, I think a great place would just be come to the website and look at the show notes, because we'll post, we'll put in Lee and Muehlman's article, which I think is a fascinating article. That was published back in 2007, I think one of the anatomy journals. And, trabecula don't lie, so there's objective things in medicine and there's subjective things, of course. And, pain scales are, in my mind, pretty meaningless, because one day my pain can be a 10 out of 10, and the next day I had a great glass of wine and it's a 5 out of 10. So it's super subjective, highly variable, very contextually, environmentally affected. But imaging is objective. On ultrasound, it either is or it isn't.
Right.
Thickened and hypoechoic.
What about X-ray? Is X-ray valid?
I think X-rays are valid to rule out, any weird osseous pathology. And I think, you should probably have an X-ray as a baseline, but don't focus on the spur, because it's not the demon. It's there actually, and as Lee and Muehlman point out in their article, that it's actually there as an adaptive mechanism. The human being has evolved for 200, 300,000 years. And that accretion of bone, what we call the inferior calcaneal exostosis, is actually not it's not a pathological process. It's an adaptive process, because pressure is force per unit area. So what the body's trying to do is increase its area, so it can decrease its force.
Right.
So that totally messes up the hypothesis that we had, where the plantar fasciitis is caused by this excess tension in the plantar fascia, because it's the trabecula respond in a way like Wolff's Law, right? So, it's like a fingerprint. It's there. It's at the crime scene. It doesn't have any agenda. The trabecula, no agenda. They just form based on the direction of force that's put upon them. And the trabecula and the inferior calcaneal exostosis, as Lee and Muehlman point out, is contrary to the axial tension load hypothesis. So why am I humbled more now? well, the more you know, the more you know.
You don't know.
Yeah,
Right.
There's that many. Sometimes ignorance is bliss, you know, especially when you're having a procedure done on yourself.
Right.
Worst thing to do is go look at that procedure before on YouTube. It's like, holy
we talk about
shit,
being
they're going to do that to me? It's like, oh.
We talk about being on top of Mount Stupid all the time, right?
Oh, yeah. Yeah. The Dunning-Kruger effect, right?
Right.
Yeah. No, I mean, and what you're up on Mount Stupid when you're probably the first 3 years in your practice and right out of residency.
Right.
And then as your experience gets more time, more scalps under your belt.
A lot of experiences,
sudden,
right?
Then you get humbled and you're just like, oh, yeah, maybe it's not so simple.
Yeah.
And you're never as confident ever
as when you first start.
Right. Yeah. Yeah. I will put that in the show notes, the Dunning-Kruger effect.
Yeah.
I think did one of them win like a Nobel Prize or something?
I'm not sure.
It might have been.
We had to look at that.
Yeah. Anyhow, they were pretty smart and, you know, so you try to stay off of Mount Stupid, which I've been up there a lot, I can tell you. I still go up there once in a while. I try not to, but you just get sucked in. So, but yeah, you know, I think in the next episodes, your question about where do I find out more about this? We got a little tangential there, but go to the show notes. We, you know, spend a lot of time on them so that people can have access. You know, click it, it's hyperlinked. They can start reading that and then they'll go down that rabbit hole. And then, you know, the next thing you know, they'll be looking at another article and then somehow they'll get on, you know, calcanei that were unearthed in caves in Majorca and look at the difference between posterior exostoses versus inferior exostoses. So there's a lot of very fascinating stuff. But, you know, the more you learn that you really don't know that much.
Yeah.
And so, and especially when you get these very sad cases and that you've done everything and you cannot, you know, and then we're looking at brain imaging now. Is it centralized?
Right.
And, you know, I mean, I think we take a very high level approach on some of it. Most of the time, of course, percentage-wise, that's a very small percentage of people that present with heel pain.
But those are kind of the ones you fixate on, the ones that you can't figure out exactly what's happening.
Right. Yeah, no, there's the surgeon heuristic where, you know, you can do 100 XYZ procedure, and if the last 2 go bad or the last 2 or 3 out of 10 go bad, the surgeon says, I must be doing something wrong. I have to change this technique. And I think we spend very little time, you know, thinking about the people that got well and did, you know, had the outcomes that they were, you know, supposed to have.
Yeah, the ones we expected.
But it's the 1 or 2 that just stand out in your mind, and it's like, wow, what's going on with that? You know, those are the ones that you agonize over. But maybe the agony causes some of the, you know, motivation to
and the innovation.
And to fight for these people because they need that. You know, they need, you know, just because you don't have the answer, there might be somebody out there that does have an answer. Or maybe technology in the future will, you know, be a solution.
Yeah, help us along the way.
All right. Well, I'm excited about having these chats and expanding our heel pain series. So thank you for coming up today. And I would encourage anybody that's listening to go to the podofinquiry.com and look at the show notes.
Perfect. Thank you for having me.
You're welcome. Thanks for coming up. I appreciate it. I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.